All right, we talked about sort of general parameters and terminology and everything for electrical stim, as well as contraindications and precautions in Chapter 11. In Chapter 12, we talked about electrical applications for muscle stim. And now we're going to talk about electrical stim for pain management. And this is Chapter 13 in the book. In this lecture, we're also going to talk about a little bit of Chapter 14, particularly the iontophoresis part. And we're not really going to talk about the rest of Chapter 14, which is tissue healing. If you hear snoring in the background of this lecture, it's the dog. She's sitting right next to me and she's snoring. So, here we are. Let's talk about the learning objectives. So, for this, after listening to this lecture, you should be able to determine the electrical stimulus, waveform, device, and electrode requirements for the application of electrical stim for pain management. Pretty easy, right? You should know how modulation affects a treatment using a sensory stimulus. What can you modulate, and is one thing better to modulate than another? So is it better to modulate frequency or amplitude? Let's find out. You should be able to state the indications for each stim and be able to determine the appropriate settings for each indication. Of course, we've already talked about indications and contraindications and precautions. We are going to review those just like we did in the muscle stim lecture, but we're not going to go into the detail that we did in Chapter 11. Remember those questions that you can ask your patient. Really good thing to ask those questions for the practical. You should know, after listening to this lecture, or this section, how e-stim is used to modify pain using a sensory response and how it's used to modify using a motor response. You should be able to explain the theoretical basis for the management of pain with TENS. Like, how does it happen on the nervous system level? And we will talk about that. So we talked about this in last summer in pathophysiology. We talked about it in the pain lecture. We're talking about it again because it's a big issue. Pain is the reason why a lot of people enter into the medical system and end up in physical therapy. But you'll see the numbers that you're seeing are $635 billion in incremental costs of healthcare and indirect costs of lost productivity. So there's a reference in the references for this lecture that refers to that. Care costs are huge, about half of that. Lost productivity, another half of that. That's a big deal. So pain negatively impacts work days. You get more missed work days. It impacts the number of annual hours and hourly wages. And so it affects people's lives on a survival level. And then pain just wears you down, too. So we talked about it in the pain lecture, but now we're talking about how we're going to address this with electrical stim. So there's actually a long history of using electrical stim for pain control. In 46 AD, Scribonius Largus was a Roman physician. He used an electric eel for the treatment of gout and headache. So I guess you just grab onto the eel and it zaps you. Not very controllable, but hey, there you go. In the 1760s, a physician named John Wesley wrote some papers using static electricity for pain control. In the early 1900s, there were some questionable electrotherapeutic devices, an electric belt, and like, wow, it cures your back pain. So the claims were pretty wild, and we don't really have any research to back that up. In 1965, Melzack and Wall came up with the gate control theory as an explanation for electroanalgesia. So I have the reference for their paper in the references for this. But in the 70s and 80s, there was a big expansion in applications for postoperative pain, labor and delivery pain, and that was largely used in Europe. It's not used in the U.S. very much. Joint and soft tissue pain, neuropathic pain, reflex sympathetic dystrophy, which is now called complex regional pain syndrome, and we will talk about that more in neuro next quarter, and phantom limb pain. So again, we're going to talk about pain over and over again because it's a really important subject. So in this particular set of lectures, we're going to talk about how to address it with electrical stim. So that we have the gate theory, the proposed theory for electroanalgesia. You get enhanced superficial blood flow with electrical stim that improves the oxygen supply and removes irritating chemical mediators like histamines and prostaglandins from acute inflammatory responses. So that's one of the proposed theories about why electroanalgesia works. The gate control theory, which is that spinal cord level inhibition. And there's this diagram from the book, and we have a bigger one on the next slide that we'll look at. In TENS, transcutaneous electrical nerve stimulation. It's electrical stimulation specifically to moderate pain. And it's the activation of the non-nociceptive A beta nerves, inhibiting transmission of nociceptive signals at the spinal cord level. There is another TENS application that is thought to trigger opioid release, and there's interesting research that goes with that. We'll talk about it in a minute. So this is that gate control theory. So the A beta fibers are the good guys. The A deltas and the C fibers are the bad guys, if you want to think of it that way. Well, they're not really bad guys. We have to be able to detect pain so we know what's going on in our environment. But the A delta and the C fibers are the nociceptive fibers. And they are transmitting their information up to the spinal cord. The A beta fibers, which we're going to stimulate with electrical stim. Earlier on, we stimulated them with soft tissue mobilization and with heat and cold modalities. This time we're going to use electrical stim to stimulate those A beta fibers, and those synapse with an inhibitory neuron which blocks those A delta and C fiber messages, keeping them from going up to the thalamus where we're going to be aware of them. So that's the gate control theory. So stimulation-produced analgesia is also thought to, with certain settings, have a release of endogenous opiates that are associated with those stronger intensity, low frequency stimulation that are right at the motor threshold. So we'll talk about motor stim versus sensory stim, but this is more the motor stim part. So we're trying to, we're doing a lower frequency just at the edge of the motor threshold, so we're looking for muscle twitching. So the research that I have listed in the references, they actually used an opiate antagonist called naloxone, and so they were able to induce electroanalgesia with these low frequency, also called electroacupuncture, low rate, strong intensity TENS, and then reverse it using the opiate antagonist. So that opiate antagonist actually binds to mu receptors in the nervous system, which are opioid receptors. And so by binding those opioid receptors, you reversed the effects of the electroanalgesia. So that's pretty indicative that the electroanalgesia is induced by causing the brain to release endogenous opiates, which then bind to those mu receptors and cause the reduced pain. So pretty interesting. That's pretty new information that's coming out. Before it was proposed that maybe that's it, but by doing this particular intervention, you can see that there's definitely some endogenous opiate release that's causing the reduction in pain. Pretty interesting, I think. So these are 3 different TENS applications that we can use for pain control, and we're going to do these in the lab. So conventional TENS is high rate TENS, uses gate control mechanism to control pain. It's a short duration, so 50 to 80 microseconds. Remember the strength duration curve, we're not going to be stimulating motor fibers with that short duration, we're going to be stimulating sensory fibers. We're getting the A betas. High frequency, 100 to 150 pulses per second. the amplitude to produce a comfortable sensation without muscle contraction. And I will modify that to say strong but comfortable. And we'll talk about that a little bit when we talk about appropriate amplitude. We're going to modulate to limit adaptation to the sensory stimulus. And this kind of TENS is most effective while the stimulation is applied. It doesn't have a lasting effect. So the second one, so that's that first graph up on the top, the high rate. You can see the high frequency there. The opioid release via low rate acupuncture-like TENS, it's repetitive stimulation of motor nerves. So it's a lower rate, you say a lower frequency. We're going to stimulate endogenous opioid production and release that's going to bind to those opioid receptors. So the long duration pulse, 100 to 300 microseconds. Remember, we want to stimulate motor nerves, so we want a longer pulse duration, but a low frequency. And the amplitude sufficient to create small muscle contractions. So we're getting twitching. Instead of tetany, like we did with muscle strengthening, we want muscle twitching with this one. This particular type of TENS tends to be effective for 4 to 5 hours after the stimulation ends. So it has a longer lasting effect because of the effect on the opioid receptors. So we're not going to use it for more than 30 minutes per session to avoid delayed onset muscle soreness because we are getting that muscle stimulation. Burst mode TENS is where stimulation is delivered in bursts or packages, and it ends up activating the same mechanism as low rate TENS, but it might be more effective since more current is delivered with each burst. So in burst mode, you get a burst of a lot of pulses all at once, and then a gap, and then a lot of pulses all at once. So it ends up feeling like that low frequency acupuncture-like TENS, but there's more current delivered in the burst. So there's all sorts of clinical indications for electroanalgesia, and Bellinger did a bunch of meta-analyses and compared a bunch of studies. The references listed in the references for this PowerPoint, but rheumatoid arthritis, osteoarthritis, dysmenorrhea, which is menstrual pain, labor and delivery, this was European research that used that, post-surgical pain, low back pain, various chronic pain syndromes such as fibromyalgia and chronic regional pain syndrome, headache, phantom limb pain, neuropathic pain from diabetic neuropathy, angina, which is chest pain, interestingly enough, and orofacial pain. So the phantom limb pain and neuropathic pain are asterisks because there are conflicting studies that, it's questionable how effective it is with those two particular things. So there are studies that show that yes, it's effective, and also studies that show that no, it's not effective. So the contraindications and precautions, we're going to go over them quickly because it's a review, but remember, we don't want to harm anyone. A contraindication is a condition that cannot be altered and precludes the use of electrical stim. A precaution is a condition that may be modified or for which additional care may be taken to permit the use of electrical stim safely. So just have those straight in your mind. The contraindications, remember pacemakers. There are different types of pacemakers that a cardiologist might screen someone during a trial of TENS and monitor their EKG. I'm not going to mess around with that. I would, if the doctor, I would have to talk to the doctor on that one and get a written okay to do it. Patients with implanted cardiac defibrillators or cardioverters or other implanted electronic devices, be careful about those. The over pelvic, lumbar, or abdominal area during pregnancy, and asking about the possibility of pregnancy before administering electrical stim in these regions. All the areas where you're not supposed to apply electrical stim, no matter who the patient is, over the neck, because we don't want to get that vagal nerve response. with phrenic nerve or urinary bladder stimulators, because a phrenic nerve stimulator is making it so you can breathe, so you don't want to interrupt that. Over cardiac or transthoracic area, over areas of thrombophlebitis or arterial or venous thromboses, over the phrenic nerve, eyes, or gonads. I don't know why you would do that, but in an area of active osteomyelitis or hemorrhage, so that's the damage, the wounds or damage, and transcranial in clients who've had a history of stroke, seizures, or TIAs unless brain function is carefully monitored. Most PT clinics don't have the capacity to carefully monitor brain function, so we're just not going to do that. Precautions. Some modern shielded pacemakers can be used with electrical stim. How do you know that what the patient has? You don't. So grain of salt on that one. Impaired sensation, impaired mentation, skin allergic responses to electrodes, tape, or gel, and cardiac dysfunction, just like we've talked about before. All of the things that we talked about in the muscle stim, not within 5 yards of diathermy units or other sources of electromagnetic radiation. Don't do it while operating hazardous machinery. One of the things that is specific to pain management electrical stim is you want to monitor a patient's pain medication intake to establish the efficacy of electrical stim versus pharmacological agents. So if they're on opioid medications, don't use low-rate acupuncture like TENS because they're competing for receptor sites. You're going to probably have a better effect with a sensory level TENS. Okay, so that's just something to think about. People with cancer, of course, if we're going to do it on someone with cancer, we want written documentation and consent of the patient and physician. Always a good idea. Same as all the other ones we talked about. Avoid placing electrodes over fragile skin, tissues vulnerable to hemorrhage or hematoma, and cervical or craniofacial regions in patients with a history of CVA or seizures. So the evidence that Bellinger and his group examined, there's limitations of examining the evidence. Comparison of the different studies is problematic because there are different types of pain syndromes that were examined. Even in one study, they had people with different types of pain syndromes. Inconsistent terminology and methods of pain assessment and outcome measures. Inconsistent or absent documentation of stimulus parameters. So you can't replicate the studies because you don't know what they actually did. Different numbers of treatments evaluated. Sometimes only a single treatment was evaluated. Adjunct therapies varied and are unaccounted for in the studies. And potential interactions between opioid medications and TENS application parameters. So if you picked Estim for your evidence-based research, take that into account. Those are limitations of the studies. So the things that we're identifying is what population they're doing it with, what was the intervention, what were the outcome measures. So we just kind of really want to have a way to look at these studies and get some useful data out of it. So because of all those limitations that I just talked about, it leads to mixed results and flawed conclusions. So you might just conclude well, there's no proof that electrical stim works. But in a couple of the other references that I have cited here, inadequate dosing, so not enough amplitude or not enough charge, limits the observation of benefits. So we'll talk about how much is enough for adequate dosing. When systematic reviews are analyzed based on adequate dose, positive effects with TENS are observed in patients with chronic low back pain and osteoarthritis of the knee. So if you look at the studies that were done with adequate dosage, you do see that it can be helpful for particular issues.